Okay, good. Dr. Gimmarco, you've been using Medistim a long time, perhaps one of our longest users. When you started doing cabbage surgery, what did you have available to you for quality control and checking for flows?
You mean at the beginning of my practice?
At the beginning of your practice.
Yeah. I didn't have anything. Nothing. We did not have any method to check the anastomosis. We didn't have any method to assess the quality of our job. And we started to have something in 1996.
Okay.
And the first equipment was a laboratory instrument.
Mm-hmm.
And there was no display. There was just a trace, just paper. And there was a small instrument with a sign, a signal about the forward flow or the backward flow. This was the only thing we had available at that time.
So did you rely on this equipment at that time, or was it sort of experimental and were you just keeping an open mind to its possibilities to actually be a valuable tool?
I should tell you that the history of intraoperative graft verification is something fascinating, because we began using a true laboratory instrument and technology developed so fast, making available for surgeons more and more precise instruments, even more, and from the original equipments we are now leading almost something very close to perfection, because we have available flow measurements and imaging, so we maybe close the circle.
Mm-hmm. Now, when you started using our device, and we didn't have a clear understanding of what the endpoints were. You know, you talk about the range of endpoints that we have now. How did you say you approached its use? Did you approach it clinically or did you approach it scientifically?
Both of them. I mean that if you talk about the practice, you definitely need to take a decision. Mm-hmm. Yeah? So if we observed a clear volume of likely functioning grafts, we were happy of that. But the problem was when we dealt with very small mean graft flows or very quite IPIs in the presence of a small coronary artery, a small vessels just revascularized, sometimes with a vein. So in these cases we took the advantage. We took the advantage to have a flow measurement device, so reducing the area of uncertainty, but we couldn't be 100% sure that anastomosis was functioning.
So this was a work in progress.
Yes, it was a work in
progress.
progress.
More and more data came. So for instance, you have come to understand the endpoints to be different than other people might be comfortable with. For instance, you like a PI of 3, others will accept a PI of 5. What's your message to the world who says, if I get a 5,
the message,
even on an artery, I'm happy?
Yeah. The message is this one. It's undoubtedly that if you publish a group of patients, a patient population, talking about a PI by 5 as a cutoff value, you need to be trusted, obviously. So the question is a good one. Why this wide range? Because probably it belongs to different size of coronary arteries in different populations in different parts of the world. So that's why probably the approach is the same, because of flow measurement, but the data and the cutoff values could be different.
Population specific.
Yes,
Yeah.
could be.
Could be, yeah.
Yes.
So the Chietians.
We published in
Yeah.
2006 cutoff values concerning mean graft flow by 15 milliliter per minute, and concerning the PI, we published a cutoff of 3.
Yeah.
but in other experiences, mean graft flow and cutoff are different. But I've heard that someone of the authors who published those seemingly high cutoff values concerning PI, they are maybe setting a bit down this level, being close nowadays by 4 or something like this.
Okay, so they're seeing things differently. In other parts of the world, surgeons have a different relationship, let's say, with flow measurements than in other parts of the world. Some surgeons might use our device and they will find a value that's over 5, that's 7, 8, or 9. And they'll say, well, I expected that high value because I have a very poor outflow bed, or I have a very sick patient with very poor targets. Do you compromise your endpoints based on the health of your patient?
The answer to this question is much complicated. I mean that, in my opinion, the target should be to work in a team, the so-called heart team. The indication to graft a vessel or not to graft it should come from a laboratory study. I mean that the cardiologist who works in a cath lab should measure the perspective of revascularization of a single vessel, for example, a specific vessel. I mean that if you can measure the fractional flow reserve, for example, you can state if a graft, if a coronary artery is to be grafted or not, has to be grafted or not. And this reflects into the surgical choice and ultimately on the results of the surgery. So I mean that we should go to the surgeon, should go to the OR with the specific and precise idea about which vessel is going to be grafted or not. This is probably one way to improve the results.
Okay. In our estimation, some grafts you have to bypass. If you have an occluded LAD, this needs to be bypassed. And I wonder if this is a measure, an incidence of confidence. I mean, at some point in your use of transit time flow, you developed confidence in the numbers to the point where you accepted these as being accurate, reliable, and predictive of outcomes. How long did it take you to get to that feeling that I now can really trust my TTFM flow data, so that I'm not going to say it's the patient, it's the procedure or the technique?
Scientific research led us to say that there are some cutoff values to be respected, but a cutoff value is not a fixed point. It is something that could be kept in mind, considering that a graft that shows a very high flow and very low PI is definitely well functioning. Mm-hmm. But as you approximate to cutoff values of mean graft flow and PI, you decrease the precision of the prediction about the patency of the graft. Mm-hmm. So, as you approximate to those values, you need something more to assess the patency of the anastomosis. And that's why, in my opinion, imaging is definitely helping in assessing the patency intraoperatively, as the transit time flow measurement could be in assessing and in predicting the fate of the graft late postoperatively.
Talking about imaging and just the future of quality assessment, do you think we're there, or do you think there's still technology or techniques or other evolutionary events that have to happen in order to continue to improve outcomes?
Where
are we? Are we there? Are we done?
Yes, and we are going to.
Yeah.
We are in a good position to reach the goal. So we increase the accuracy of the intraoperative graft verification. We increased and we led the accuracy using transit time flow measurement and imaging, high resolution imaging. We led the accuracy almost by 1. It's a good goal. Where should we go? One improvement could be the chance to reconstruct three-dimensionally the shape of the anastomosis and the shape of the coronary artery. This is possible probably just changing the software or making something on the software. And this could be a very nice improvement in the future. Yeah.
Okay. Anything else you want to say to your peers out there who don't see the world of patency the way you do?
No, I just want to tell something for young surgeons, young generations. They need to prepare to another kind to make surgery, at least coronary surgery. The importance of self-control, the importance of intraoperative graft verification is as important as an auto-education for surgeons. I mean that as you control the grafts, you educate yourself, and you educate yourself on the way of perfection, I should say. Mm-hmm. I mean, you become more and more expert, more and more accurate in doing anastomosis. Because if you have the control, the intraoperative control as a target, that's the mirror of your job. Yeah. And if you mirror yourself, you will be, you will look definitely more and more handsome, you know.
Yeah. And take feedback wherever you can get it.
It's
whether
good feedback,
it's from people
yes.
or devices. Yes.